welcome to our e-poster for GNRS 5301 Pharmacological Principles of Clinical Therapeutics. Our group consists of Caitlin Avery, Fallon Braden, Tiffany Crochet, Stacy Montejano, and Chantel Johnson. We're here to discuss Section 2, Case Study 2, Iron Dextran Therapy. Our case study begins with Mary, who's a 63-year-old female with end-stage renal disease, who's receiving hemodialysis 3 days each week. She has anemia associated with chronic kidney disease and has been taking polysaccharide iron complex 150 milligram by mouth daily, along with ascorbic acid 1,000 milligrams by mouth twice daily. After 6 months of treatment, her symptoms are not improving, and the decision is made to initiate intravenous iron therapy with iron dextran. A little background with end-stage renal disease. The hyperfiltration of the nephrons are impaired. The kidneys will adapt by increasing the rate of filtration in normal nephrons, but eventually all the remaining glomeruli of the nephrons are damaged. As mentioned in the case problem, anemia is a complication due to CKD. Since the initial treatment failed to correct the anemia, iron dextran therapy was initiated. Tiffany is going to discuss the first key point when considering iron dextran therapy.
Hello, my name is Tiffany Crochet, and I will be discussing how the first dose of iron dextran should be administered. According to literature, I found up to date on the treatment of iron deficiency in hemodialysis patients. Iron dextran is usually the last resort to use unless other agents are not available. With iron dextran, there is a 1.5 to 2% rate of anaphylaxis and other adverse events. Due to the increased risk of these adverse events to the iron dextran, it should be administered slowly via an IV infusion and a 25 milligram initial dose. You do not have to pre-medicate the patient before administration, but epinephrine, diphenhydramine, and corticosteroids should be readily available at the bedside. Now Stacy will talk about our next section. Thank you.
Thank you, Tiffany. My name is Stacy Montejano, and I'll be explaining what precautions should be taken for prescribing the first dose or a test dose of this drug. Hemodialysis patients should be given a test dose of iron dextran. According to UpToDate, because of the risk of anaphylaxis, if iron dextran is to be administered, an initial test dose, usually of 25 milligrams, must be given prior to administration of a full dose by slow IV infusion. As in Tiffany's presentation, she stated that it's not necessary to pre-medicate patients prior to the test dose, but to have emergency medications such as epinephrine, diphenhydramine, and corticosteroids should be readily available at the bedside. Due to the likelihood of a delayed response, these precautions should be taken with the second and third dose also. Monitoring the patient for subsequent reactions and patient teaching regarding reactions and side effects is key. Some side effects include abdominal pain, nausea, chest pain, shortness of breath, flushing, rash, and hypotension. According to Lexicomp, the latest information on iron dextran, during all iron dextran administrations, observe for signs or symptoms of anaphylactic type reactions. Fatal reactions have been reported following the test dose of iron dextran injection. It has also occurred in situations where the test dose was tolerated. That's why we have to continue monitoring with the subsequent second and third dose. Now Caitlin will be going over the next section.
So I'll be discussing other IV iron options, which these include epoetin alpha and darbepoetin alpha. Both of these work by signaling your bone marrow to make more red blood cells. Both can be given IV or sub-Q. IV is the recommended route for patients who are receiving dialysis. Both recommended for those with a hemoglobin of less than 10. And both medications have an increased risk of death, cardiovascular events, and stroke if the targeting hemoglobin is greater than 11 in those with chronic kidney disease. Epoetin alpha, the recommended dosage is going to be 50 to 100 units per kilogram per dose IV or sub-Q 3 times weekly initially. For patients on dialysis, like our patient, we're going to administer it IV, and we're going to initiate treatment when hemoglobin is less than 10. Some dosage considerations include titrating to keep hemoglobin between 10 and 12. You want to increase the dose by 25% if after 4 weeks of therapy the hemoglobin has not increased by 1 or falls below 10. And we want to decrease the dose by 25% if the hemoglobin approaches 12 or is increased by more than 1 in any 2-week period, because again, it puts them at an increased risk for death, cardiovascular events, and stroke. For darbepoetin alpha, we want to initiate treatment when the hemoglobin level is less than 10. For our kidney disease patients on dialysis, they recommend starting the dosage at 0.45 micrograms per kilogram as an IV or sub-Q injection once weekly as appropriate, or they recommend starting the dose at 0.75 micrograms per kilogram as an IV or sub-Q injection once every 2 weeks as appropriate. And that's for the patients on dialysis. Some dosage considerations with this medication is if the hemoglobin has not increased by more than 1 after 4 weeks of therapy, we need to increase the dose by 25% when appropriate. We need to decrease the dose by 25% if the hemoglobin increases by more than 1 in any 2-week period. For our patients on dialysis, we need to reduce or interrupt the dose if the hemoglobin level approaches or exceeds 11. And for our patients who are not on dialysis, if the hemoglobin level exceeds 10, we need to reduce or interrupt the dose and use the lowest dose sufficient to reduce the need for a blood transfusion. Both medications following initiation of therapy and after each dose adjustment, you need to monitor their hemoglobin at least weekly until the hemoglobin is stable and sufficient to minimize the need for a blood transfusion. Thereafter, the hemoglobin should be monitored at least monthly, provided that the hemoglobin levels remain the same. And then next, Fallon will be presenting. So here's Fallon.
Okay, so there are a few things that we need to consider before initiating iron dextran therapy for a patient. If the patient has already had the product, we want to make sure that he or she did not have a reaction to it. According to Burns 2021, iron dextran has a significant risk of anaphylaxis. Iron dextran is used after oral administration, has been ineffective in treating anemia. So unless it's indicated and oral therapy isn't working, then this would be the next step. Also, the patient must stop taking any oral iron supplements prior to getting iron dextran. Prior to initiation, it is important to ensure that lab values show anemia. So draw CBC and look at the hemoglobin hematocrit, but you want to also check out the ferritin and transferrin levels as well. According to Philia 2020, there's an increased risk of adverse reactions for patients that take ACE inhibitors while getting this product. Okay, so now Chantel will be going over our 3 questions for our audience.
So the questions we have, number 1, what are some complications with CKD? 2, when should iron dextran therapy be considered? And 3, what are some side effects of iron dextran therapy? This now concludes our e-poster presentation, and thank you guys so much for tuning in. Goodbye.